Hello, everybody. Welcome to Etiologies Part 2. This one is, thank goodness, much shorter. I think there are 18 slides, and we'll go through some of them rather superficially, in fact, so it's not going to take very long. I guess my original intention was to do Part 1 and Part 2 together, but it became very obvious that that was too much. So anyway, I have prepared from a large set of slides, Etiologies Part 2, and it's the end of the larger set. And basically, when you complete Part 2, you will have done it all. And you will know a lot about etiology at that point. So let me share my screen here. I'm going to try enlarging this and then, well, okay, so yeah, we'll go. Hang on a second. Here we go. All right, that's just the introductory slide. And going to the next one, we're going to start this segment with intracranial neoplasms. Now, neoplasm just means new tissue. It's tissue that basically shouldn't be there. It would be a tumor or a cancer. And these are the most common types that affect the brain: gliomas, meningiomas, pituitary adenoma, neuronoma, and metastatic carcinoma, meaning the carcinoma type of cancer started someplace else in the body, often the lungs, for example, and spread to the brain, perhaps other areas as well, and then 20% others. Now, you've probably heard of some of them. If you were to work in as an SLP in a cancer center, such as City of Hope, you would learn quite a bit about these and the prognosis for them and the treatments for them. But in most medical centers, or medical settings, I should say, the typical SLP will run into these occasionally. And usually it's on a patient who's been newly diagnosed and perhaps might be on their way ultimately, after a diagnosis is made initially, to a cancer center. So most of us haven't worked in a cancer center. I have not. I've worked with a few of these patients, but not long term. And I don't know a lot about cancer. So I have a resource I'll show you in a slide or two. But basically, the diagnosis goes like this. There always starts with a history and physical. It starts with a patient who has a complaint. They could go to a physician, their own personal physician, with their complaint, and start that process of a history and physical. And then often the next step would be a computerized tomography, a CT scan of the head, or a magnetic resonance imagery, MRI of the head, which will reveal most neoplasms. Sometimes the neoplasm is biopsied. They would do that by putting a small hole in the skull and penetrating a needle to the place where the neoplasm is located and extracting just a small amount to study. Sometimes lab studies of the blood, without getting into the cranium, just simply lab studies of the blood will be indicative diagnostically. So there's a lot of diversity in the types of procedures that are done simply to diagnose. And that is where this book comes in. When I get a patient who has a tumor, and obviously I'm seeing them because they have a swallowing issue, or they have a speech and language or cognitive issue, and not working in the cancer center, I don't know a lot about the prognosis of whatever type of neoplasm it might end up being. And that's where this book comes in. It's updated every single year, current medical diagnosis and treatment. You can get it on download it on an iPad or another device. And I don't update every year, but I do update frequently, because especially in an area like cancers and tumors, the diagnostic procedures are changing rapidly, and the treatments are changing rapidly, which affects the prognosis. And as an SLP, basically, when I see a patient, I want to know, are they going to get worse? And if so, what is the expected time course? Are they going to remain the same, or are they going to get better? Is there sometimes there's not a cure, but there's something that one or more treatments that can extend life considerably. So I need to know that in order to be able to determine a prognosis as best as possible, and to formulate a treatment plan that, correlates with the facts of the situation. And, of course, you can discuss that with a physician, the oncologist or the neurologist or whoever who is working with the same patient and knows the most. You can consult with them. But when you go see a patient for an evaluation, you're going to write up the evaluation right away. And you may not have the opportunity to consult with somebody before you have to finish it. In other words, you can't come back and finish your evaluation the next day. You need to do it right away, because a lot of times they're waiting to determine if they can give the patient sips of water or pills or full-on meals or whatever it might be. So there's an urgency involved. And when I have to write my prognostic statement, I don't want to be totally, out of touch. Even though obviously nobody's going to perfectly be able to state what a prognosis is on a given patient, certainly not me. But I want to come as close as possible and not be obviously to the rest of the team out of touch with what's going on. So that's my purpose in wanting to have a book like that I go to. And I think I mentioned this before, but the book is updated every year. And it has just maybe 3 or 4 pages on, I would say, virtually anything that you will encounter in a medical setting. You can look it up. And in those 3 or 4 pages, you will get what the presenting signs and symptoms might be, how it gets diagnosed, what the tests are, what the treatments are, what the efficacy of the various treatments is, and what the prognosis given those treatments might be. So in just a few pages, you could kind of get what, as an SLP, you want without having to read, an entire chapter. By the way, the chapters are divided down into disease and injury categories, and they are updated every year by an expert, not by the 3 authors here. They just are, they're editing the book every year. But the various experts in these little niche areas of medicine write the chapters and update them every year. So you're getting the most up-to-date as you possibly can in a convenient way. It sounds like I'm selling the book. I'm not. I don't have any interest in McGraw-Hill. So what are the possible treatments? They include surgery, radiation, chemotherapy, combinations of the above. Rehab, you will see if you work in an acute rehab patient setting, or even in a skilled nursing facility that offers rehab, which they all do, by the way. You'll have patients who've been through some of these things and are there now for rehab to return as much function as possible. And sometimes palliative comfort measures and hospice care are the direction that is taken. And SLP has a role in that, by the way. We'll talk more about that in 543, the dysphagia seminar. All right, moving on to a different category. And again, one that's quite diverse, and the book comes in here. Bacterial meningitis, bacterial encephalitis, brain abscesses, tubercular meningitis, which is, differs according to the organism that causes it, neurosyphilis, which is a late effect of syphilis, and infections by protozoa and worms. Yes, I said worms. You won't encounter many of these in most settings, but you will. Over the years, you're going to have probably just about all of them, I would say. But you won't know much when you get one because you haven't encountered many of them. And so, again, the book comes in. Here, by the way, just so you know, I'm not making up the worm story. This is from an article, which I put into the module, by the way. It's just 2 pages, from the New York Times health section. Just, what is that? Several weeks ago, August 29th, 2023. A 3-inch worm was found in a woman's brain. And how did they find her? Well, she was sick and they couldn't figure out what was wrong with her. And it took about 6 months. And finally, she started developing neurologic signs. And they ended up doing neurosurgery on her to try to identify what the issue was. And they found this worm and removed it. And she is doing better, by the way. But she's from Australia, but she was gathering, she liked to gather plants near a swampy area to put into salads. And that is probably how she picked this up. And it got first into her digestive system and then worked its way through to get to the brain. So that's, and is it really rare? Not if you're looking from the world perspective. There are, the article said, millions of people who have these worms. All right, what's the diagnostic process? Looks kind of like familiar, doesn't it? History and physical, CT and MRI scans, lab studies of the cerebral spinal fluid can start to identify the nature of the infectious agent. Pharmacologic treatment is offered, surgery sometimes. Obviously, the woman with the worm had this worm removed. Sometimes palliative measures and comfort and hospice, depending upon the disease again, and sometimes rehab. So there's great diversity at its low frequency. That's why I'm not going into great detail, but I want you to be aware of it. And as an SLP, if you're working in healthcare, you will encounter those things. All right. Now, here we go with infections again. The last category was non-viral. These are viral. As you probably know, non-viral infections tend to be more susceptible to treatment by medicine than viral infections, but healthcare is getting better at reaching the viral infections too. And so this is the list of them. And this would be the process for diagnosis and treatment. Familiar list, isn't it? And now we go to head trauma. And I'm going to go into a little more detail on this one because you'll certainly encounter it if you're an SLP in healthcare. If you work in acute care, if you work in skilled nursing, you're going to encounter, and if you, certainly acute rehab, you'll encounter traumatic brain injury. So it's a form of brain injury caused by trauma. I'm just mentioning that because when you hear, at least when I hear the word injury, I think of trauma. But a stroke injures the brain too, and that doesn't involve what we would conceptualize as trauma. But basically anything that happens to your brain can be referred to as a brain injury. But we're talking now about brain injuries that are caused by trauma, such as auto accidents and so forth. And in traumatic brain injury, there are several things that can occur that are bad, obviously. One is there can be contusion at the point of skull-brain interface. And I'm going to elaborate on that comment just a little bit more in a subsequent slide. The second is there can be hemorrhage. It can be epidural, subdural, subarachnoid, or intracerebral. We talked about epidural and subdurals before when we were talking about strokes, even though an epidural hematoma is not a form of a stroke, or epidural or subdural hemorrhages are not types of strokes. They're things that can occur during with head trauma. And typically with epidurals or subdurals, what happens is that there's a small fracture of the skull that where the fracture crosses one of the little arteries that are in the dura, and they break the artery. And then just depending upon, the geometry of the situation, the blood then leaks out of that artery and accumulates between the skull and the dura, or between the dura and the subarachnoid membrane, which in case that would be a subdural. So epidural is between the dura and the brain. Either which way, they're contained. In other words, they start to grow because blood is leaking in there, but they're contained. It doesn't go all over. It stays in a small space, which is easily identified with a CT scan, by the way. So that kind of makes sense. But now, how would you get a subarachnoid? Basically, when there's traumatic brain injury, the brain can be so contorted that it tears an artery. It can just be any artery, depending upon the geometry of the forces, that are applied to the brain. But it can tear an artery and leak into the subarachnoid space. Even at one of the arteries inside the brain, can hemorrhage, and that would be an intracerebral hemorrhage. I just want to point out the difference between intracranial, which simply means inside the skull, the cranium, or intracerebral, which means inside the brain tissue. So that those all can happen. They don't necessarily happen or happen very significantly. You can just have the third one, and you'll still have a traumatic brain injury. It's referred to as diffuse axonal injury. And basically, that doesn't even show up on a CT scan, at least not initially. But it's injury of the brain at the level of axons, where they have the shearing forces applied to the brain have just torn synapses and caused problems with the functioning of neurons at more or less an individual level, but very diffusely. In other words, a lot of them. And the reason I say the CT scan won't show it initially is if all the person has is diffuse axonal injury, and they come in, they could even be unconscious, do a CT scan. If they don't see any hemorrhages, any of those hemorrhages, and they don't see any significant contusions, they don't see anything. It can look normal. But now, where does the CT scan finally show? Well, because neurons are going to die over the course of a little bit of time, few weeks. And so if they do a CT scan later on, the brain will look smaller. And it shows its smallness by enlargement of the ventricles and enlargement of the subarachnoid space, the space around the brain, between the brain and the skull. So I think of diffuse axonal injury as sort of the hallmark characteristic of traumatic brain injury. So anybody who has a traumatic brain injury and has any of the cognitive consequences of that traumatic brain injury do have diffuse axonal injury. And then if it's even more traumatic, they may have the hemorrhages and the contusions and so forth. So those are all referred to as primary injuries. They actually occur at the time of the injury, at the time of the trauma. I wanted to just elaborate on the connection or the interface between the brain and the skull. Now, in the last slide, I said that the brain-skull interface, and it was in reference to contusion, because when, let's say, somebody hits the windshield of a car that has hit a tree, whatever, their brain keeps going, but the skull stops when it hits the windshield. And so the frontal lobes are going to have quite probably a contusion because it slammed into the front part of the skull. So depending upon the direction of the forces that are applied to the brain, the contusions can, if there are any visible contusions, can be in any location. But I referred to the skull-brain interface. There are a couple other important areas to be aware of too. It has to do with the dura mater. I think you might just think of the dura mater as being, a membrane that coats the inside of the skull, and that is true. But it has a few little extensions which help to support the brain in place. One is called the falx cerebri, and the nature of the tissue is that of dura. And what it does is it's a piece of dura that comes down between the two hemispheres. And so what it does is it holds the brain in place so it doesn't shift around as much. It's supportive, in other words. And it's quite tough. If you just touch dura, you'll see it's quite tough. It's not very flexible at all. And I want to point out this particular shape here. You see this? That looks like the shape of the corpus callosum. And the reason it looks like that shape is because the falx cerebri comes down to the corpus callosum. That's where it stops. It can't go any further because it's encountered. It's between the two hemispheres, but once it gets there, it's the corpus callosum, and then below that's the midbrain and the diencephalon, and so it stops. What's the significance of that? It's a tough edge that can cause problems when that brain shifts around. Then there is another very similar type of structure. It's made out of dura that is supportive in the back part of the cranium. It's called the tentorium cerebelli, and it is between the posterior part of the cerebrum, which would be more or less the occipital lobes, and the cerebellum. So the cerebellum is under it in what is called the infratentorial space. The infratentorial space, everything down here. And what's down there? The brainstem and the cerebellum. What's in the supratentorial space? Everything up here. The two hemispheres, one on one side, one on the left, on the other. And so here we've got a tentorium cerebelli, and here's its edge. again, a tough edge. And it more or less wraps around the midbrain. There's not a whole lot of space in there. It's wrapping around the midbrain. This little opening, by the way, through which the midbrain travels, brainstem's below, cerebrum's above, it's referred to as the a tentorial notch. That has a lot of, and here we see it on this view in which we're looking down. Here is the tentorium cerebelli. Here is the notch, and the midbrain comes right through it. But what's the consequence? Well, when the brain is injured in trauma, it will swell. It will tend to swell. And management of that swelling is a big part of why people survive brain injury now much more than they did a few years ago. But it'll start to swell. And then depending upon what's swelling most, it will tend to herniate brain tissue into any opening it can find. So let's say you have more swelling of the right cerebral hemisphere. The parts of the cerebrum, cerebrum that are up against these edges will start to herniate through. So you get little parts of the temporal lobe starting to squeeze down through the tentorial notch, or squeeze under the edge of that falx cerebri and put pressure on critical things. The midbrain is really critical. You really can't live without it. So the herniation of cerebral tissue through that notch, pressuring the midbrain, is a source of death very rapidly too. So that's a critical problem. Another reason why, remember when we talked earlier about removal of part of the skull. So that's something that can happen, or maybe that's still to come. That's one of the treatments, actually. Okay, so let me advance here. So I think I've said everything. I just wanted to have you be aware of these edges, and the nature of the problems that are caused by those edges. Not only during the trauma itself, because there's an interface there, so brain, falx, and tentorium cerebelli interface, just like I said, brain-skull interface, same thing, but also the significance of the herniation of brain tissue through the openings and putting pressure on critical parts of the brain. All right. Now, we went through primary injuries that occur at the time of the injury. There are secondary injuries too, and they are edema, which is swelling, ischemia, you know what ischemia is now from our discussion of stroke, deprivation of blood supply, and hypoxia, which is deprivation of oxygen, probably due to breathing problems that occur in, collaboration with the injury, I guess you could say. So these occur later, and depending how well the management has occurred, how quickly, for example, and how effectively and how successfully, complications can be avoided. Edema is a big cause of death. So when the swelling occurs, you start to get the herniation of brain tissue in every direction it can go, and through those various little openings, and pressure on the midbrain and so forth. Ischemia is deprivation of blood supply. It could be because of the heart stopped. It could be because there's pressure on a vessel that is keeping blood from going to a certain area. And then hypoxia, deprivation of oxygen supply, typically due to respiratory problem that occurs in concert with the injury. So these are, emergency medicine is much better, and the emergency response actually to the victim is much better than it used to be. And the medical care that they start to apply is immediate. It used to be, what did they call it? Ambulances. And you don't remember this, but before the days of EMT, which is done by the fire department, there were private ambulances. And when somebody had a severe injury, like a severe traumatic brain injury, they referred to the whole process as grab and run. So they pick them up as fast as they could and get to an ER. But that can be too late. So now EMTs are trained to get in touch with they actually talk to the physician immediately and let them know what's going on, what they're seeing, what they're measuring, and they start to get orders right away. So they deliver medicine to reduce the edema, of course, make sure they're breathing and their heart's beating to get blood and oxygen to the brain. So, and then the improvements in care continue in the ER and in intensive care and so forth. So, whereas, 30, 40 or 50 years ago, rehab programs weren't that big because a lot of people didn't survive. And nowadays, particularly if you work in traumatic brain injury rehab, there's a lot of patients because survival is much better. I wanted to mention the difference, this distinction between closed and open head injury. What I've just talked about up till now doesn't mention anything about an opening, and many times in trauma and auto accidents, for example, the skull may have a fracture, maybe it doesn't, but it's basically intact. But there can be open head injury too, in which case you get the kind of the global effects of that shock injury to the brain, plus localized effects of wherever the opening is. Now, how would you get an opening? Well, a gunshot would be a common one. So when a gunshot occurs, there is focal injury, and you'll get focal signs. You'll see in those patients focal signs later on after they've survived. Depends where the bullet was. Could be motor signs, sensory signs, visual, whatever it is. Refer to your Brodmann's areas, and that kind of tells you. But in addition to that, that bullet causes a huge shock wave to go through the whole brain. So the person with a bullet wound, which is a penetrating and an open head injury, obviously, has the effects that we've just gone through, the primary and the secondary, plus they have local effects where brain injury was actually damaged by whatever it is that is penetrating the brain. Okay, I wanted to talk about how severity is graded. Obviously the CT scan and an MRI scan gives a kind of an indication of how severe the injury is, but they actually grade it using a behavioral observations and get more information out of that. When you look at the prognosis, the research on prognosis from a traumatic brain injury, there's research that looks at the relationship between the results of a CT scan and outcomes in recovery. But a lot of it is about how severe it was initially and how severe it was, an hour later and a day later and 2 days later. And those data on level of consciousness, basically, is more predictive of how well the patient's going to do in the final outcome. And so they start measuring consciousness actually out in the field with something called the Glasgow Coma Scale. It's a 4-point scale. It has three parts to it. 3 or 4, SLPs don't use it much, but if you see your traumatic brain injured patient and you look back at their records from when they were admitted, they'll have the Glasgow Coma Scale, and they have it goes up to 15 points, and it's on three dimensions: movement, eye opening, or eye gaze, I think they call it, and then verbalization. So there's a 5-point scale for each one, and it adds up to 15. And so they start measuring it and writing the time that they're measuring it out in the field, and they continue it in the ER and in critical care, because those numbers and the slope of the curve are very predictive of outcome. There's a lot of research on it if you're interested. Now, we'll get later on, when we get to cognition in this course, we'll talk about how SLPs measure consciousness, because we don't use the Glasgow Coma Scale, but your patients will have those measures on them. And it's good to know what it means, obviously, because you're a member of the team too. While we're talking about consciousness, I want you to know about 2 types of amnesia and the confusing use of the terminology, some terminologies related to amnesia. There is something called retrograde amnesia, and retrograde amnesia is an amnesia for a period of time before the injury. So how long that period of time is before the injury, measuring backwards, that the patient can't remember anything, that's very predictive of outcome from that injury. Now, what exactly do I mean? Well, let's say somebody is injured on a football field. They're down and they aren't responding at all at first, and then they start to verbalize and they ask them their name, and that's long-term memory if you ask somebody their name. And then you ask, where are you right now? And if they say, well, I'm on the football field, they remember, at least a few hours before, apparently, because they know where they know where they were at the time of the injury. If they don't know they were on the football field and they have no clue, they have a longer period of rest, and they can say, well, what did you have for breakfast this morning? Of course, you have to know what they had for breakfast this morning, and just probe back in time to see how long that period of retrograde amnesia is. So the longer back in time you can't remember anything, the worse the injury and the worse the outcome. That's retrograde amnesia. And then post-traumatic amnesia, SLPs we don't really use that term, but the psychologist or the neuropsychologist who evaluates the patient with you in acute rehab, they use it, and physicians use it. So we need to know what it is. But post-traumatic amnesia is just the problem with learning things or remembering things that is a hallmark of traumatic brain injury. So every traumatic brain injured person that you see in rehab is going to have trouble learning new stuff. They'll be having trouble with orientation, and they don't know what they had for breakfast, and as they get better, of course, hopefully. But that's referred to as post-traumatic amnesia. And that actually is the cognitive outcome, if you think of it that way. It's not predictive of the outcome, but it is a hallmark of traumatic brain injury. All right, what are the causes? Now, I think you know this. Automobile, motorcycle, bicycle, falls, physical abuse, including shaking infants. That's very dangerous for the brain, because shaking can bounce the brain around inside. And then other forms of violence, such as gunshots and explosion related and so forth. Okay, now we switch categories again. And again, I refer you to the book. Some of these are so common, you won't be looking them up in the book all the time because you'll work with them frequently. Alzheimer's disease would be a really big one, very common. Why are these listed together? Because they are quite different. Because they all involve degeneration. They all are progressive. They start mild and get worse and worse and worse. Alzheimer's disease starts very minimally. I mean, just relatives begin to think, I thought I told you that, and they don't remember, and it gets very, very bad, to the point where the person can't talk and then can't eat and usually gets pneumonia and succumbs to that. Pick's disease is a very similar kind of degenerative process, but tends to focus a little more posteriorly in the brain, more around the parietal lobes, whereas Alzheimer's starts in the frontal area. Huntington's chorea is a motor disorder. It's a chorea, so we'll look at this a little bit when we get to the hyperkinetic dysarthrias. And it's not real common, by the way. I've seen probably 2 or 3 people, and it was always that they were admitted to the hospital for something else, and they coincidentally had Huntington's chorea. And I typically saw them for swallowing evaluations, and often the Huntington's chorea was related to the swallowing issues that they were having, but that they're generally admitted because they got pneumonia. Then Parkinson's disease, you all know about that. It's a movement disorder. And it does progress to the point where cognition can be involved, but it's slowly progressive. And if you work in any kind of a healthcare setting, you will see many. Progressive supranuclear palsy is, now the supranuclear part of that title means that the problem with the motor system is above the lower motor neuron. We've kind of labeled that different things, haven't we? Including we've identified that it causes spasticity, not flexity. So this is a palsy, a weakness caused by a problem with the motor system above the lower motor neuron, and it's progressive. And why it has kind of a vague name, and that's because they don't exactly know what causes it. So I think there might be some newer research, but I haven't seen many people with it, just a few. And then amyotrophic lateral sclerosis is a progressive disease that usually progresses over several years, 2 or 3, sometimes as short as 2 or 3, from normal to expired. And it involves upper and lower motor neurons. So that's why it's so devastating. Progresses to the point where the person can't breathe. So people generally will have made a decision already as to whether they would want to have a tracheostomy and put on a ventilator or to go to hospice. It seems like more and more people go toward hospice. I do remember seeing a lady about 20 years ago who chose to get a tracheostomy and a feeding tube and go on a ventilator. And she then ended up in a long-term acute care hospital. And she eventually was practically not really arousable. She's certainly not communicating. So she had survived by that time about 20 years. So anyway, kind of 2 directions people can go. There are 2 different types depending upon where the disease starts in terms of its effects. One type starts in the extremities and works toward the axis of the body. People with that have a longer lifespan expected because you can survive without your hands and your feet functioning fully or at all. But the other type starts with the axis muscles and progresses from there. So very often, their very first sign will be hoarseness. Your larynx is at the axis of the body, and it's very finely tuned, precisely tuned, and you're going to hear hoarseness if it's not working even a little bit off, and it'll have its effect. So vocal signs and also swallowing. Sometimes I've seen quite a few people who went to their physician and the first thing they did was order a swallowing evaluation, and we did that modified Barron swallow and identified some of the issues. And then of course we end up wanting to get a neurologic evaluation, and sometimes they come from the neurologist for the swallowing evaluation, but many times those people walk in for their test. They're walking, their problem is the axis of the body. So it can start in the periphery and work toward the axis, or start in the axis and work toward the periphery. The second group, when it starts in the axis of the body, structures of the axis of the body have a shorter life expectancy, which makes sense. And then we get to multiple sclerosis, basically. The reason it's titled demyelinating diseases is multiple sclerosis is not the only one, but it is by far the most common one. And it can produce localizing signs for sure. You can one day have, a weak upper extremity, and then it kind of gets better. So there's this exacerbation and remission effect with multiple sclerosis. And then the next day it can be your left toe, or it can be your right visual field. It can be anything that we know of as a localizing sign. There can be a period of exacerbation in which a sign emerges and then it goes away. And they'll tend not to duplicate themselves each time, but to be here and there and all over. So over time, more and more of the brain and the nervous system actually are damaged and produced, eventually cognitive deficits. When the damage is diffuse, it can even be mild, but diffuse, there will be mild cognitive deficits, in addition to the waxing and waning of things that are more observable. This is an area where there's a lot of research and a lot of progress too. Some people do extremely well for many, many years. I don't know, you may not remember the election of 2012 in which Mitt Romney, Senator, who was, I think, a senator at that time, but he'd been a governor too, ran against Obama. And his wife was kind of in the news because she was campaigning, and she'd had MS for like 20 years. And that was 2012, 11 years ago. She'd had it for a long time, but she was doing very well. And she said that there were periods of time when she just couldn't get out of bed, but then it'd get better, and then she'd go on the campaign trail. So she looked fine, but I'm sure sometimes she didn't. But anyway, my point is, even though you may encounter quite a few cases of multiple sclerosis in your career, I like the book for that because, you know, I get not what they were doing 10 years ago and what was working 10 years ago, but what's working now with multiple sclerosis by looking at a current medical diagnosis and treatment 2023. I'm not selling it, by the way. I already said that. Okay, and then we get to, we're almost done here, metabolic disorders of the nervous system. Let me go to the second one because it's so easy to understand, I think. Hyperglycemia. Well, it's a blood sugar disorder. So your blood sugar gets out of balance and you start to be shaky and sweaty. And it can be bad enough that your cognition gets worse. And then you can become unconscious and you can die, all in a pretty short amount of time. So hyperglycemia is an example of a metabolic disorder. The blood is having trouble metabolizing sugar at that particular moment. And it affects mentation, cognition, it affects everything, but mainly it starts with confusion. And so that's a common one. Another common one, if I could just skip down to number 4 here, disorders of electrolytic balance. You need to keep the strength or the concentration of sodium, potassium, and chloride. Not only those, but the reason I'm bringing those up is because they are responsible for the action potentials and for the balancing your neurons. And they get the kidney function, it can get those mixed up and out of balance very easily, particularly in older people. So a lot of times people will get confused and enough to scare themselves or their relatives. They go to the ER immediately. They're going to test their blood and their urine for electrolytic balances. And if they find an imbalance of sufficient magnitude, they may attribute the cognitive problems and the consciousness problem they're having simply to that. So you're going to see a lot of it. And sometimes it's going to be coincidental to what you're there for. You may see an older person who's had a stroke and you're seeing them basically for the aphasia, the swallowing and whatever. And then one day you go in and they're real confused, not like yesterday, but more so. And there's a possibility of this. So of course, as a member of the team, we would always alert first the nurse and make sure that the physician is alerted to that because this is the first thing they'll think about. If they don't have a focal sign, they'll start testing for electrolytes. Dialysis encephalopathy. Now, encephalopathy, I'll get to this one up here, but encephalopathy simply means pathology of the brain. It's a very general term. And your brain starts not functioning very well when you have chronic long-term dialysis. So dialysis, as you know, is to make up for kidney failure. And it does a very good job of it. And people can survive for many years on dialysis. But you'll notice in the patients that you see in the hospital who are on dialysis that their cognitive functioning and their swallowing, by the way, is at one point one day, and 2 days later, it's quite different. Could be better, it could be worse, depending. But there's a cycle. And the cycle is related to their dialysis. They're going to be dialyzed twice a week. So on the day of dialysis, they had a lot of toxins in their body, and then they went and had a traumatic procedure. They're wiped out, and then they're not so good the rest of the day. But the next day, they're at their best because the toxins are cleansed out of their body. They're over the trauma of the procedure, which is not that traumatic, but it does fatigue them. So that's their best day. And then the next day, not quite so good. And then the next day, kind of bad. And then it's dialysis day again. So they go through that cycle. And with working with swallowing with these patients, who may have their swallowing issue from something else, by the way, but nevertheless, if they have dialysis encephalopathy, you need to cope with it. So that is another metabolic problem. They're having trouble metabolizing the toxins that are affecting their neurologic function and the function of their total body. So I think we've talked about everything now except hypoxic hypotensive encephalopathy. Remember, encephalopathy is just brain pathology, very general. And in this case, it's caused by hypoxia. For example, somebody who has cardiac arrest, they may have long-term cognitive consequences of that, especially if they weren't revived right away. You know, if they have put the paddles on immediately and get the heart restored, that's one thing. But if they do 30 minutes of CPR and then use the paddles to restore the beat, that's another thing. So the outcome may not be as good. And what would the problem with their cognitive functioning be caused by? Hypoxic encephalopathy. And hypotensive encephalopathy is not enough pressure of the blood getting up there. So either which way, the brain is not getting sufficient oxygen. And all of them are non-localizing. In other words, you don't get a hemiparesis or a loss of a visual field or anything like that. You get first very minimal cognitive deficits, what we call confusion, even barely detectable confusion, worse and worse and worse, until finally loss of consciousness. That's at the other end of the scale of cognitive functioning. And here is a reminder about the book. And that is the end. I'll stop sharing and just mention that in this same module, we have another lecture on how to write up 2 sections of the report. One has to do with getting all the information we've gone over in these 2 lectures on etiologies and interpreting it, figuring out what it is you need to put in your report and what you can forget about, and how to write it up, actually. And then the second section that is fairly easy is a short section that describes their level of function before they got sick and came to the hospital with whatever we're seeing them for at that time. That would be referred to as prior level of functioning. So there's a short lecture, not many slides. And since it's sort of learning as we go, we're going to do that one in class. So I do not have a recording of that. It will take us very long in class. So we'll cover both of those things, and then we'll do some practice writing. And that is it. I will see you later, and have a great day.